start.
So now it's recording.
And now it's recording.
Okay.
And like I said, when it gets right at 30 minutes, it just turns itself off because it was over there, right there.
So the other thing that Rob and Kobe wanted me to do was kind of a brief overview of what the MPD's office was about and all that. Do you want me to wait and do that at the end? Because this one, this is being taped. Again, we probably won't tape that part of it.
Sure.
Okay. Groovy. Okay. Right on. For those of you who don't know who I am, I work with the medical program director in Clark County. We do clinical oversight for all of the EMS providers from the river all the way to the mountain. So with that, we just went through a big major overhaul on protocol revisions for the county. And historically, so historically, our EMT providers have sort of functioned off a set of state standards that were developed in 2005 and tended to not get upgraded. We would implement EMTB protocols specific to certain things, like an ALS assist protocol that we'll go over here in just a little bit. But the intent of putting this set of protocols together was to create a document that every level of provider could work off of. Okay, so we've changed the format a little bit. It's not only ALS protocols that are in here. The ALS is determined by certain things throughout the document, as we'll see as we go through the program here. But basically, we put this document together so every level of provider can work off it. Even EMRs can work off it. And I think the only EMRs in the county are administrative people. Okay, that button works really good. The other one here. Okay. So what we did with the protocols is we changed the structure and we changed the format. We created a table of contents. Essentially, this is a working document. It's something that you can work off. We don't encourage people to work off it in the field, but it's available if you need to. So it can be a reference for things like, protocols that you don't use on a regular basis. Things like, wound packing, or what are the things that I actually can do to help assist a paramedic. So it's a document that you can't, it's designed, formatted to be used on a smart device of some kind. An iPad, one of those little Windows things, pad things that you guys are going to be getting or you have now. You can use it off your smartphone. That's the whole intent. So we created a table of contents. All the topics are alphabetized. For those of you who were exposed to our protocols previously, they were kind of hit or miss and smattered. Although you actually had to read and look for something and then go find it. So this is a lot easier. We created hyperlinks so you can use it in your smart device pretty easily. The other notation here where it said it's a good idea to be familiar with content. If you're trying to figure out what the stroke protocol is, you can go to the stroke protocol, or do you call it stroke, or do we call it CVA, or cerebrovascular accident? Do we call, when we want to decompress a chest, for example, do we go to pleural decompression, or do we go to chest decompression? So the whole point is you need to know what things are, how they're labeled in the document, so it makes it easier to find. Eclampsia previously, and it was its own protocol, its own section. Now we've included it in the general overall OBGYN section. There's a lot of things like that are not separated; they're included in a general section. The page numbers now are continuous, which is nice. Previously, we divided it up into sections, like a trauma section, a medical section, peds section, and then some other stuff. Now it's just numbered continuous, so it makes it easier to find stuff. And that was the whole intent of doing that. We've created 5 different divisions of the protocol itself. We have the specific treatment protocols, i.e. the stroke protocol, there's a cardiac protocol. So treatment guidelines for specific things, specific ailments, if you will. Then we've created a procedures section. The procedures section is the procedures that you do. In procedures, there's an IOS, an interosseous infusion section, or an interosseous placement section. Procedures, like there's a CPR section. What does high performance CPR mean in our system? Well, you can go to that section and find out. So that's the procedures, the things that you'll actually be doing. There's a spinal immobilization procedure section, and we'll get into some of these as we go along. Then we have what we call COPS. COPS are our specific operating procedures. Every county in the state of Washington has specific county operating procedures. These are things like, where do we take trauma patients? What happens, what is our interaction with law enforcement and other allied agencies? What sort of dispatch system do we use? Things like that. These are all identified in our COPS. This is basically kind of the administrative functioning of the system. So COPS are included in their own specific section. And then we've included a section of medications. For you guys, your list of your medication formulary is going to be rather limited. Things like Narcan, epinephrine, the stuff you use in cardiac arrest. I would say the nerve agents, but we don't have those in there. We took those out because you'll never, ever use them. So we've created a medication section for reference. The medications are nice because they're listed. They give you indications, contraindications, dosing, and peds doses as well, which we find is probably the most useful part of it, because not everybody remembers what the peds dose for epinephrine is in cardiac arrest. So look it up. Okay, that makes it easy. The last section is a reference section. There's miscellaneous things in here. I think we put in like the rule of nines and estimating burn surface area, Glasgow coma scale is in there, and other stuff. What's fun is when you guys get the document, you can actually look and see what's in there. So as we talked about before, we've created, so the way the structure of the protocols itself in the document, when you read them from top to bottom, it starts with the BLS level treatments, and it progresses into the ALS level treatments. So within each protocol itself, you start from, just like when you treat a patient, you start from A and you go all the way through to however far you end up going, okay? So the nice part about this document is it functions for every level of certification and every scope of practice, okay? ALS interventions are designated by a blue cross. So anytime you see that within the document, that means it's a paramedic level, advanced level intervention. Well, actually, I should take that back. It's a paramedic level intervention. We've written these protocols. Is anybody an IV tech in here? No EMT, IV tech? You were? Not anymore? Okay. We actually allow for certain things for IV technicians to do as well. So anything that's indicated by a blue cross right there is a paramedic level intervention. And then the BLS treatments and interventions are listed previous. So anything that doesn't have that falls within an EMT scope of practice. There's the big fancy red arrows are medical control concurrence procedures. Whenever that's in the document, that requires a medical control consult. For you guys, that's not going to be so much of an issue. That's typically with the paramedic. The paramedic will be required to talk to the medical control physician. You guys all understand what medical control means? Medical control, yeah, essentially it's the physicians that, the ER physicians at B-Cell Southwest, they've been designated by our office to the state to be medical control or online medical control physicians. What we're talking about today, the protocols, that's offline medical control, okay? That's the stuff that's our scope of practice, that's what we do. That's offline medical control. So online medical control is when you're speaking to a physician on the phone, getting assistance of some kind. Okay. So those are the big red arrows. The medications list, which is a new thing that we've done. We list all of the medications that we have in Clark County in our formulary. I think there's 48 of them, I believe. I don't know, I haven't counted. The dosing and indications for all the medications is listed, and it makes it easy for a real quick reference. We've also listed for each of the medications, and I've just put an example on the slide that you see right there, which is Decadron, which is an alternative steroid that we carry. So sometimes you've all heard of the medication shortages that we've had and issues with getting medications at times. We have alternative medications that we can use when we run out of stuff or can't get stuff. So that's basically how that thing works. Continuing on with the structure and the format changes, we talked a little bit earlier about how each of the protocols contains a hyperlink, right? So when you're treating a patient for abdominal pain, typically abdominal pain in and of itself is a symptom, right? Nobody ever goes to the doctor and leaves and gets diagnosed with abdominal pain. It's a symptom of something else, okay? So the whole point of hyperlinks is to link you to other spots that say, okay, if this or if your patient is exhibiting this, then jump to this protocol, okay? Abdominal pain can be what's abdominal pain a symptom of? Anybody have any ideas? What causes abdominal pain? Other than gas, which gas can cause abdominal pain?
Growth sinusitis.
Sure, absolutely. That appendicitis. So appendicitis can also cause something else that can kill you, shock. Okay? So there are certain times when you need to go to something a little bit more specific than just the general abdominal pain. Okay? So that's the whole point of the hyperlink thing. We've created it when I'll talk about the Universal Patient Care Protocol here in just a minute. But so if you're treating a patient with abdominal pain and they're hypotensive, then you go to the shock protocol, because at this point abdominal pain really doesn't matter. You're wanting to treat them for shock. Okay? And then if they start to vomit, they have significant nausea, we have specific protocols on how to deal with that. Okay? So that's the whole reason for the hyperlinks. We don't want you to get stuck on a symptom. Okay? Treat something, but at the same time you're going to hear or respond to patients that have abdominal pain all the time. So any questions about how the whole hyperlink thing works? Okay, so hyperlinks, anything that's blue and underlined is a link that you can actually click on. Okay, some of the other things that we've incorporated into the protocols, in each section is a PEDS section, so you can see that right here in the seizure protocol. Essentially, treatment for kids is specific to a certain syndrome, a certain problem. And being able to include that in each specific protocol makes it easier for you as a clinician to manage what the patient is dealing with right there, rather than having to think in your mind, oh, I got to go to a different section. Previously, what we did is we created a whole pediatric section, and then repeated everything that we talked about for everybody else, and that didn't seem to make a lot of sense. So within each protocol, there's a PEDS section. So that particular example on the right, the seizure protocol, that's kind of how the format of the protocols work. And you can see you start with basic level intervention. You treat per the universal patient care protocol. If they're in status seizures, obviously then you move into ALS and you start to give anticonvulsant therapy. But anything that's not indicated with a blue cross is a BLS EMT level intervention. So if you're ever curious about what your scope of practice is in the county, it's written down now. It's kind of cool. Okay, let's see. Am I done with that part? Yes. Okay. So what's the other thing that we included in this set for your reference? I often would get questions about, and I still do actually, and probably always will, which is okay. It's kind of what I'm here for, but what are we allowed to do at our specific scope of practice as a common one? Am I allowed to do this in this specific situation? And then oftentimes, I'll say yes or no. And then the response, and usually this comes from administration because now there becomes a union issue or there's some question that they have, is, well, who allows that to happen, or what specific thing allows that to happen? And this is why we put in, this is essentially the WAC for scope of practice for EMS providers. We've put the state document within our protocol so it gives you a place to reference what actually allows you to do the things that you do. So basically 246976 is WAC specific to EMS, and then the 182 designator we started at somewhere around 0, and I think it goes up to 300 or 400. But basically, this is specific to pre-hospital care, EMS, and it indicates that you as EMS personnel are authorized to provide patient care in these specific situations. You have to be in an emergent pre-hospital setting or during an inter-facility transfer, or en route to a facility in the back of an ambulance, okay? So your scope of practice is only authorized by the state if you're functioning as an emergent responder, okay? So essentially what this means, and we have this issue, is that you cannot function as an independent field practitioner at places like the fairgrounds, or when you're off in, you're camping or hunting at hunt camp with your buddies. You technically don't have a scope of practice at that point, okay, as per the state's guidelines. You have to be functioning as an emergent provider, dealing with emergencies or transporting a patient to further care. As part of that, you have to be performing for a licensed EMS agency by the state of Washington. Your approved scope of practice is limited to or included in your improved guidelines that you were taught, the curriculum by which you were taught, or any specialized training that you got. Okay, so for those of you who've been around this county for a little while, you go through an EMT program, and if you didn't get it in your EMT program, you got it through your agencies, which is SGA training or iGel training on how to insert an iGel. That's called specialized instruction. And all of that scope of practice has to be included in the MPD protocols. Okay, sometimes MPDs have different levels of protocols for different level of providers. Some counties allow EMTs to do CPAP if they've been trained in it. Some counties don't. Depends on the MPD. Okay. Okay, so we talked about offline versus online medical control. And basically what this talks about is medical control that exists either offline or offline. And if you don't have online medical control, offline medical control, i.e. protocols, your scope of practice is the criteria, if you will, by which you need to perform. It's essentially what that says. This one's kind of important. All pre-hospital providers must follow state-approved triage procedures, regional patient care procedures, and county MPD patient care protocols. You guys are required to follow the protocols that your medical program director sets forth. Okay? You're also required to follow the state-approved triage procedures. And what this specifically means, state-approved triage procedures exist for trauma patients, which means you can't take a trauma patient to a medical clinic. You have to take a trauma patient to a trauma hospital. Okay? Same as stroke and cardiac arrest or cardiac patients, you have to follow local, state-approved, regional-approved patient care procedures and MPD protocols. Okay? So that exists in state law. If anybody ever asks you why, or if you disagree with your MPD's protocols, it doesn't really matter because you have to follow them. It's state mandated. Okay. Here's the one. So everybody else is an EMT, right? I got that correct. Okay. I'm not going to detail every one of these because that with the heat up would put you to sleep in about 3 minutes. Less than that, 30 seconds. But if you guys are ever curious about what you can do, it's listed. This is kind of cool. This is in protocol now. Okay? So it's specific in these. This is a state document. It came right out of the same place all that other WAC 246976 mumbo jumbo stuff I just talked about came from. It's all in the same spot, and it exists in protocol now. So if you ever have a question about what can I do or what's my scope, it's listed in there now, which is kind of cool. So hopefully it removes some of the questions. So basically, just to kind of give a overview of how this works, when you see an N means that it's that particular procedure, medication, process, whatever's listed in here, is part of the national standard curriculum. It's taught to every EMT that takes an approved EMT course. Same with paramedics and same with EMRs, which are the only ones listed on here. There's another section, and I think we revised the protocol. There's a section for advanced EMT. So advanced EMT is almost a paramedic, but not quite. We don't have advanced EMTs in Clark County, but it's included in there because it's a state document, and we needed to put it back in. So anyways, EMRs, EMTs, advanced EMTs, and paramedics, their scope of practice is listed. If it has a W right here with the asterisk by it where it says continuous positive airway pressure, CPAP, that means that it's a Washington approved edition. And you have to get MPD approved training. You have to get trained in how to do the procedure. So you can have CPAP in your protocols, but you can't do it until you're trained on how to do it. Okay? It's basically what that means. And if there's a double star, fortunately it's right there. Like I talked about before, a double star is it's in a Washington edition to the national scope. But the double star means that I, as the clinical guy for Clark County, have to apply and get permission by the state to conduct a special training course. So I have to go through a process to become a training course to teach you guys on how to insert eye gels or supraglottic airways. And that's essentially what this particular protocol speaks to. Airways not intended for insertion into the trachea, i.e. a King supraglottic airway eye gel, which isn't listed on there. Okay. So that's basically what this document speaks to. It's what's your scope of practice is specifically. Under cardiovascular care, that's pretty much standard stuff. You can do CPR, actually, hopefully, and we'll be really good at it. Pulse oximetry is part of your standard training. There's nothing in here really. Oh, down at the bottom, do you guys know what VADs are? Or LVADs? Anybody ever heard of that? So an LVAD, a left ventricular assist device, there's a lot of patients that are really brittle, congestive heart failure patients, pre-cardiac transplant patients that back in the old days used to stay in the hospital for months. But nowadays they send them out, and basically, essentially, it's an implanted pump that replaces. Well, it doesn't replace. It kind of replaces your left ventricle, or it assists it a little bit. Okay. Anyways, that's what that is, and basically, all you do is follow the directions on the machine. If you have a patient like that, follow the directions on the machine. Or there's a phone number there, call the phone number. Say, what do I do? Let's see, what else is kind of import with this? Okay, this is always the big one. Not so much with city, with you guys working in the city, because you always, almost always, 99% of the time have a medic that's on the scene. So basically, your focus is to do the ALS assist protocol. But sometimes I get questions: what medications can we administer? What medications and how can we give it? Which is a pretty common question. You guys as EMTs in our state can give IM medication. With specialized training, can give IV medication, except in Clark County, we don't need for EMTs to give IV medication. You can give IO medication as well, which means it's essentially medication that's already prepared and you can push it. And we'll talk about what those specifically are in just a second. You guys can administer medication via the typical normal pathways. Most of these are specific inhalation, intranasal medication. What medication would you give intranasal? Narcan, yeah. So then what? This is the other important thing. So you can give Narcan, glucose in certain situations, epi for anaphylaxis. That's the IM one that you can give. Back in the day when we first came out with this thing, you had to give epi via auto-injector, right? You had to have that little, well, most of you guys are young, you don't remember her. That was dinosaur age. Now you don't have to use the pre-filled thingies. You actually can withdraw it from a vial and stick it in their thigh or shoulder or some big muscle somewhere. You can find it. So glucose for hypoglycemia. The nerve agent is still one of the only auto injector things that we have out there, although sometimes you guys might see, especially the cops, you guys might see auto injector Narcan. But for the most part, needle administered. And then that's pretty much it. Any questions about medications that you guys can use? Okay, so we went through basically scope of practice stuff. Now back to specific protocol and how they work. We've created this new thing this year, and this is based off. I'm going to back up just a little bit. Part of the reason for the creation of these standardized protocols. These protocols exist in every county within our region. And our region is consisted of Clark-Cowlitz, Skamania, Klickitat, South Pacific, Wahkiakum. I'm probably missing one in there somewhere, but anyways, you get the drift. Southwest Washington area, okay? These protocols will be consistent throughout all of those counties. Part of that process was, okay, how do we create structure for all of this so it meets, because everybody's scope is just a teensy bit different throughout all of those counties. We followed the recommendation. There's a national EMS document that's been created that's sort of a all-encompassing national scope of practice. It starts at the BLS level and goes all the way through ALS. Dr. Whitwer is one of the writers of that. So out of that was born some of the new things that we've created in our specific protocols. And one of those was this, which is the Universal Patient Care Protocol. In the national document, this protocol is about 13 pages itself. And we decided that was a little bit long. We decided to shorten it just a titch. And basically what the Universal Patient Care Protocol is intended to do is to give you a guideline to follow on every incident that you go to, okay? Every patient care incident that you're gonna experience, you're gonna start with this. And basically what it means, and we'll go through this real quick. I'm not gonna get into it in any detail, but you basically, so the first thing you do is assess your scene, make sure it's safe, there's no hazards, all that sort of stuff. Okay, I'm sure for those of you who just recently graduated from EMT school, you get the whole, you had to go into a scenario and you said, BSI scene safe. And I always ask, what does that mean? I really don't understand. But now what it does is hopefully it makes you think about it. Don't go into hazardous scene. Make sure it's safe for you, right? Request additional resources as needed. Declare an MCI if it's appropriate, or go through your company SOP as to, or your agency SOP as to what you do when you have multiple patients. Typically, how is an MCI defined? You guys know?
Any scene that overwhelms the responding agency's resources.
Mm-hmm. Absolutely, yeah. In certain situations, that could be 2. In other situations, maybe that's 5. So it's just dependent upon your local agency. Okay, use appropriate PPE as necessary. Right now, we are in the midst of what in our county? This is, we haven't been declared yet, actually.
Flu season?
Yeah, but we haven't been declared yet, so I stand corrected. Well, it's cold and flu season, so if you go into a scene with a patient that's coughing and complaining of flu-like symptoms, what do?
Mask.
Put a mask on, yeah, because having the flu sucks. What should you do before that?
Get your flu shot.
Get your flu shot, yeah, absolutely, definitely. So be cognizant of the scene that you're going into, use appropriate PPE for that scene, okay? You might not, you're gonna use different PPE depending on the specific scene that you go into. Okay. Then start your initial patient assessment. You determine responsiveness, adjust accordingly as you go along. And then you figure out what's their chief complaint. What is going on here today? What's wrong? You do the ABCs, or if it's a cardiac arrest case, you do the CABs, which essentially means start CPR immediately. Okay, if somebody's unresponsive, unconscious, unresponsive, start CPR. And then C, cardiac arrest guidelines, which it doesn't show on here, but there's a hyperlink to that. Isn't that kind of cool? Hopefully you're not sitting there reading these and clicking as you're going along, but you know, it's there in case you need it. So then after we've gone through the ABC, CABs, we secure an airway, start oxygen as appropriate, and then control any major hemorrhage. Evaluate their responsiveness. You guys need to get really good at doing a Glasgow coma scale, okay? So interpret level of consciousness by a Glasgow coma scale. So it's something that you can look at, just look at it, and you know, a normal dude is 15, somebody that needs to be intubated is 8. Okay, so anywhere in between there, kind of get a good idea of how to describe somebody's responsiveness by using the Glasgow coma scale. Because AFPU means nothing. Okay? That doesn't mean anything. Use a Glasgow coma scale. And then expose the patient as appropriate to their complaint, scene conditions, weather, bystanders, etc. You know, sometimes it's not appropriate to expose somebody when there's a whole bunch of people standing around, so you need to take measures to fix that. Also within the universal patient care protocol, monitor their vital signs, which include pulse oximetry, something that you guys can do, right? What does pulse oximetry measure?
Oxygen saturation.
Of what?
Your blood.
Yeah, hemoglobin, good, okay. End-tidal CO2 and get a blood glucose reading as appropriate, okay? Can monitor their ECG, and why don't you think there's a blue cross with that? Because you guys can actually apply electrodes, okay? So it's part of your ALS assist protocol, which we'll get into here in just a little bit. Establish vascular access as appropriate. That's the EMT-IV, can do IVs and IOs. Secondary survey, sample, blah, 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 all the above, or below. Any questions about the universal patient care protocol? A key consideration, and this is another part of the way the protocols exist, is typically there may be an introduction, treatment section, then we always put in a key consideration or precautions specific to a protocol. In this particular case, if you can't get a medical history from a patient, look for medical alert tags, you know, notes stuck to the refrigerator, things like that, that can give you an idea of what their medical history is. Also, always their medications can give you an idea. And then there's a pediatric section here, and specific to the universal patient care protocols, to use a pediatric specific weight-based guideline on how to deal with PEDS issues, medications, you know, ET tube sizes, things like that. Those, we consider that those are Broslow tapes. Okay. The pediatric assessment triangle, if you guys don't know what that is, be very familiar with it. The assessment triangle is essentially, it lets you know, it kind of is a guideline on sick versus not sick. Okay. Critical patient care, cardiac arrest, trauma, high acuity medical scene, blah, blah, blah. After the call is over, this is a guideline that we've put in here. We really want you guys, if you have the ability and the time, to do a hot wash. Okay, talk amongst your own crew, because you guys 3 or 4 man crews, or there might be 6 or 8 of you there. Talk amongst yourselves to figure out what did we do good, what could we improve upon, and the goal here is to do it interagency, is to do it with the transporting agency. And for you guys, most of the time, almost all the time, it's going to be AMR. Okay, some of you run some calls with Camus and then maybe mutual aid with Trunk Country, but do a hot wash after a call. We talk about medication administration, blah, blah, blah. That's it on that. Okay, any questions about the Universal Patient Care Protocol? Have you guys seen this document, by the way? No? Okay. I'll make sure that, I know Rob's got it. But these guys should at least be able to peruse it when they get a chance. Okay, probably one of the biggie for you guys. The ALS Assist Protocol. You guys can assist with ALS procedures. After your proper training, you need to get trained in this stuff. Okay? Placement of 12 lead electrodes, so you can put the electrodes on the chest. This really isn't a hard thing to do, but it's something that you need to be trained on how to manage. Okay? Number one, not everybody's chest is the same, and you need to know the appropriate landmarks on where to put the electrodes. If you guys happen to get there before a medic is there, and you put the electrodes on, you can tell them what the monitor says. Okay? Because when you hook it up, the monitor is going to tell you what its interpretation of that particular EKG is. You can tell the responding medic what it says. You can't play mini cardiologist because you saw it on TV or you stayed at a Holiday Inn Express and try and diagnose what the 12 lead is. It's hard enough for tenured doctors to read those things sometimes. Okay, you can do drip. You can put drip tubing into fluid resuscitation bags. Blood glucose determination is appropriate, and then once again the special training with the eye gel. That's the only supraglottic airway you guys will be in touch with. And then intranasal Narcan, IM, Epi for anaphylaxis. Okay, I'm trying to find the sweet spot here. I think it's right here. I think. Okay, other things that, let's see here. Okay, you need to do MPD approved training, right? So within your ALS Assist protocol, you guys need to be trained on how to do these things. Usually a paramedic will be present, but in emergent situations, you can do it without the paramedic there. And then the last one, which is very important. Anytime you're asked to administer a medication, this is typically if your crew happens to be shorthanded and you guys might be running a cardiac arrest, you're asked to push a medication. If you're trained on how to push the medication, you can put, which you'll get during your orientation here. You need to verify what medication and what the dose is. So that means if paramedic X says, please give the patient Epi, you're going to look at it and say, Epi 1 to 1,000, 1 to 10,000. The paramedic's going to give you a appropriate answer and what the dose is. You guys need to check and recheck, okay? So just make sure you're pushing the correct medication. Medication errors always happen when there's multiple people involved. Well, they don't always happen when multiple people are involved, but they happen more frequently when there's multiple clinicians involved in the procedure, okay? So, it's a lot easier not to screw up when you're actually the one pulling the med out of the kit, putting it in the syringe yourself, and giving it yourself. Always verify, if you're asked to give a medication, always verify the dose, the type, and the route. Okay, new protocol for this particular version, blast injuries. And this once again is part of the national core curriculum. Blast injuries really isn't a huge thing around here now that they've legislated out fireworks to a certain degree in the city. In the county it's still a major issue, but for you guys, most of the fireworks injuries reduced dramatically this year. But anyways, blast injury, essentially it talks about the different injury patterns in blast injury. Primary injury pattern is pressure, basically that impacts the body surface that moves it somewhere, typically you have ear issues, pulmonary damage. Secondary injury is from projectiles. There was a bomb that had fragments of something within it, or it was in the dirt and it blew rocks and dirt all over the place. Penetrating trauma is a secondary injury pattern in blast injuries. Tertiary, so when the victim gets blown somewhere, there's injuries associated with that. And then the rest of them, crush injuries, burns, asphyxia, anything else that's associated with the blast, with the incident that the blast occurred in. Treatment for blast injuries, manage hemorrhage, secure the airway, very important. And they're going to have breathing issues, okay, so they get high flow O2. Be prepared to provide positive pressure ventilation. Blast injuries create lung injuries. Remember, lungs are hollow, so they can create injuries, and injury patterns in lungs typically result in fluid that you need to help blow off, essentially. So that's where positive pressure ventilation comes in. Cover open wounds, blah, blah, blah. And then the ALS intervention for blast injuries is dealing with tension pneumothorax. Okay, and that's a paramedic ALS level procedure. Circulation, start in a large bore IV, treat shock per protocol, and then be prepared to manage traumatic brain injury. Spinal immobilization will be paramount in these patients. And then manage amputation, and those are all hyperlinks. These are all hyperlinks to specific protocols that follow with this. But in blast injuries, there's a lot of considerations that you need to deal with. You guys have any questions so far? Okay. So management for cardiac arrest. For cardiac arrest in Clark County is a total team approach. Cardiac arrest, the importance of management always lies with the majority of personnel that are on scene, which is typically EMTs. And the whole point of this, the whole point of cardiac arrest management, and we have data to prove this now, is that early CPR, early defibrillation, results in life save. Those are all EMT scope of practice procedures. So the focus is BLS management on cardiac arrest in our county. So we establish unresponsiveness, identify absence of pulse and respirations, continuous CPR for 2 minutes if downtime estimated at greater than 5 minutes. If less than 5 minutes or a bystander CPR, do CPR until the AED or monitor is applied. What this means is that when you guys respond to a cardiac arrest patient, if they've been down for greater than 5 minutes by the time you get there, which is most often the case, then you will do CPR for 2 minutes. Your focus is high quality, high performance CPR. And that's always starts with compressions. Okay? Ventilations are minimized. You manage an airway when you can and you have enough personnel. And we do that here by inserting an eye gel. So, as a provider, as a BLS provider, you start CPR immediately. But if you have a patient who you might have witnessed the arrest, which is very common, start your CPR and have your partner get the AED ready, because once again, we talked about early CPR, early defibrillation, right? So we don't delay any of these things. So we start the CPR and then we get the AED ready immediately. Instead of, in the first scenario, with the longer downtime, the focus is on good quality CPR, okay? good quality CPR on both, but you do 2 minutes of good quality CPR in the first scenario. And then be cognizant of bystander CPR. So you guys are going to respond to a multitude of these cases. That's just the way it is. This is one of the most unhealthy counties in the state, and I don't know why, but it is. Yeah, our save rates are going in the crapper just because there's so many unhealthy people here. The whole focus for you guys is to get there quickly, start CPR, apply AED as quickly as possible, but high quality, good performing CPR is what saves patients. So once you get the AED on, you hit the analyze, follow the instructions, or if there's I'm not quite sure why this is in here because, well, it's designed actually to mean that if you actually have the monitor defibrillator applied as well, but paramedic interpretation is not going to be of an AED. Okay, this should be of a monitor, the actual monitor, the actual light pack. Oh, I know the other point that I wanted to make. When you guys arrive to scenes and you have citizen CPR that's being done, make sure you note good quality citizen CPR means that they're doing good quality compressions. If grandma is trying to do compressions on grandpa while he's in his easy chair and she weighs $110 and he's probably 265, those are probably not quality compressions. But if grandpa is on the floor and grandma's being helped by, her grandkids, then maybe he's getting good quality CPR at that point. It's really important to note that, especially in your documentation. Good quality CPR. Okay. All right, so you analyze, you do the AED thing, listen to the prompts, continuous CPR for 2 minutes, insert the SGA, do IVIO, and the whole point with all of these things is do not interrupt CPR to do that. You can put in an I-gel without interrupting CPR. You can manage an airway without interrupting CPR. Oops, I think I skipped a page, didn't I? No. All right. Use a weight-based system for treatment of pediatric cardiac arrest. Broswell tape. And then if patient is unresponsive to this stuff, then follow death in the field. Now, that's a general cardiac arrest management protocol. That's what we do in all cases of cardiac arrest. We get into specific different rhythm interpretations, i.e. VFib, asystole, PEA, and specific protocol for those rhythm interpretations. But that's the general cardiac arrest management protocol. Okay, AED. And as you can see up here, we've gone from protocols or treatment protocols. Now we're kind of in procedure section. As you can tell, I haven't gone through every protocol that we have in the document. It's 150 pages, and it's not appropriate to do that. What I've taken is a smattering and the changes and the things that are pretty specific to you guys. So moving from cardiac arrest management to what's the procedure for applying an AED? And that's the whole point for the jump here. Establish unresponsiveness, pulseless, and apneic. Once again, continuous CPR for 2 minutes with the time designators in there as well. Apply the leads, defib pads. The nice part about our county is you have a choice in cardiac arrest. You can apply the electrodes per the picture on the little electrode package, okay? Or, and we kind of prefer this at times, is to do an AP placement. So basically, one electrode goes over the heart, the other electrode goes over the left inferior margin of the sternum. So that's an anterior posterior placement. Or you can follow the picture on the package, either one. If you follow the picture on the package, then the ALS crew, especially if the patient's in refractory VFib, which means but they're continuing in defib over a period of time. If you guys have gone anterolateral, they'll go anterior, posterior with their electrodes, so now you have two different choices. Okay, I digressed again. Please go on, continuous CPR, supraglottic airway, which in our case is an iGel, weight-based system for pediatric patients. So that's the application of the AED. The defibrillation sequence, once you hit the button for analyze, if shock is advised, you defibrillate, make sure everybody's clear from your patient so you don't defibrillate them. And then you jump immediately into the analyze, or into the continuous CPR for 2 minutes, okay? The whole point of this is to minimize the time off chest. Okay, so once you hit the analyze button and somebody's doing the CPR, and then you stop, you hear all the noise and everything, you jump. If you defibrillate or whatever the thing says, you jump right back into CPR as quickly as you can. You don't mess around feeling for pulses and all that kind of stuff. You jump back immediately into CPR. Minimize time off chest. That's the whole goal here. Okay, so we defibrillate as prompted if necessary. Continuous CPR, then analyze, and then over, basically rinse, repeat. Is kind of how that whole process works. Repeat the CPR, analyze, defibrillate sequence until no shock advised or arrival of ALS personnel. Any questions about AED? If return of spontaneous circulation, if you guys are running a code, if you're doing a special event standby somewhere, you happen to be running a code on your own with an AED, if the patient regains pulses, you stop, assess their vital signs, support their airway, follow the return spontaneous circulation protocol. If no shock advised and no pulse present, as per the directions previously, if the AED says no shock advised, you jump right into CPR again and reanalyze after 2 minutes. If the patient's not responding to treatment, see death in the field protocol, and this is really not going to be too germane to you guys, because by that time you'll have a paramedic on scene. And then this is, so this protocol is for every other agency in the county as well, including BLS agencies that may respond without a paramedic. You need to submit a written record of what you did to the MPD's office, but in your guys' case, most of the records can be written by the paramedic. Okay. Part of cardiac arrest management is airway management. Indications, airway control, you need to protect their airway, you need to control their airway for whatever reason. Because they have inadequate ventilation, they're not oxygenating appropriately. So this is a new protocol management process for us in this particular version. Because we started, the whole point was to start with the basic stuff and then progress into the ALS stuff. So previously we had an intubation and an RSI protocol. Well, you can't really get there until you manage the airway from a basic standpoint. So that's why this is included in here. So provision of supplemental oxygen, we talk about use of a nasal cannula, rebreather mask, partial rebreather mask because we really don't carry non-rebreather masks, even though we call them that. We also talk about blow-by oxygen, and it's appropriate for use in PEDS patients typically. Use a nasopharyngeal or oropharyngeal airway when you can, if somebody's obtunded and unable to maintain their airway. We often say, instead of an oral airway, if somebody's obtunded enough to take an oral airway, you should put an iGel in instead. Okay, if they don't have a gag, it's a better airway. you need to be cognizant if you do fix whatever's wrong with them, be cognizant about yanking it out if necessary. But if somebody can take an oral airway, they can take an NITO. Maintenance of airway oxygenate. We don't want them just to oxygenate. So we use end-tidal CO2 to measure that. We use end-tidal CO2 on all intubated patients. A PEEP valve is basically CPAP, but it goes between an ET tube and a bag valve mask in cardiac arrest, and it does the same. Essentially, it does the same thing. We speak specifically to trauma patients. Maintain cervical spine protocol. Okay. They need an airway, but make sure that we don't pit them in the process of providing an airway for them. Okay. Okay, and we talk about following an advanced airway protocol if you can't control or maintain their airway with those things. But as BLS providers, you guys will be able to manage an airway with a bag valve mask, and nasal cannula. Those are very effective ways to help temporize if somebody's having ventilation issues. That's a great way to help temporize the specific issue until ALS management can happen. Any questions about airway control or airway management? Some of the stuff we use. Okay, hemorrhage control is another new protocol that we put in because of the whole stop the bleed focus that we've had. So we follow the universal patient care protocol. Direct pressure and elevation is the first thing that we do to help control external bleeding. Direct pressure is the #1 method we have pre-hospital, and we have all these other fancy things. We have wound packing potentials, we have tourniquets and all that, but by far the best way to stop bleeding is direct pressure. If it's not effective, use a commercially available tourniquet. Okay, that doesn't mean take your belt off and wrap it around the leg. It means we actually have these cool little, I don't know if they're Iranian, Iraqi, or whatever they are, tourniquets, but they actually work pretty good. And if you guys are in the lab sometime, a hemorrhage control lab, put them on yourself. They actually work really well. Don't leave them on. Okay? Just quick, not a long-term thing. Follow manufacturer's recommendation for use of the tourniquet. Always note date and time. Always write it down. The typical tourniquets have a little label. Always write down the date and the time you put it on, because that allows the trauma surgeon to know, is this limb salvageable? If it's been on for an hour, maybe not. But for 20 minutes or so, yeah, that's going to be a situation that's stuff that the surgeon needs to know. Do not remove the tourniquet prior to arriving to definitive care. Kind of a no-brainer thing. If one tourniquet doesn't work, put 2 tourniquets on. Do a better job of direct pressure. If somebody puts on an improvised tourniquet, once again, this goes back to the whole stop the bleed thing. There's, back in the day, it used to, we would see AEDs in public places. Now there's going to be tourniquet packs in public places, especially in this particular culture of the need of certain people to shoot up public places. There's going to be tourniquet packs that exist there. And with that, there's going to be an advent of the public that are going to be putting on tourniquets. So if you respond to the scene, a bystander placed tourniquet, you need to check it, #1, to make sure, is it designed to be a tourniquet, or is it a piece of piano wire and a stick? Probably suggest you take that off. So you're going to see these things. Make sure they're used effectively, and if they're not, use the ones that you carry. Or use the ones that's there, but follow the manufacturer's recommendation. Okay. You remove or replace the improvised tourniquet as time allows. We have a wound packing protocol, which we'll talk about here in just a minute. This particular, and this, because I think this is on tape for other agencies, wound packing might be something that we're going to be changing here shortly. I'm not sure yet, so don't quote me, but we might be using a technique for wound, and wound packing is basically, it's for an area where direct pressure doesn't work, and the whole process involves taking Z-fold gauze, which is really, really long, and you shove it in a wound, and you keep shoving it in a wound until the bleeding stops. Well, when you shove it in the wound, you're technically supposed to take the bleeding source or the great vessel that you're trying to stop the bleed from and push it against something hard, which is almost always what? Bone. Well, in a situation where you have a gaping wound, there's a potential that that bone might be fractured. And when you stick your fingers into some place that you can't see, you have a greater potential of cutting yourself. And most of the patients that we see that we may be packing a wound might not have the best of lifestyles. So we don't really understand what sort of things we're infecting ourselves with. Hiya.
Just found a pound of coffee in my drawer, thank you.
So wound packing is a very effective method to stop bleeding, but at the same time, we don't carry Kevlar impregnated gloves, I don't think anyways. So we may be going to a new procedure, I'm not sure yet, we'll see how this works. But we take a urinary catheter that has a 5 cc balloon on the end of it and shove that into the wound and blow up the 5 cc balloon instead. So we'll wait and see, but that may be an addition. I don't know. One of the trauma surgeons is really trying to push that. So details to follow with that. If there's an amputation involved with this hemorrhage control situation, there's a specific protocol for that. And then follow shock protocol, which you should with any patient that has a issue with hypotension. Okay, perfect segue. We talked about this wound packing thing. Essentially, it's like cling or Curlex that's wound up into a roll, but it's Z-folded. So basically, you can keep shoving it in there, and when you pull it out, it's not like the old days where they would pack with 4x4s, little 4x4 gauze pads. Well, if you didn't keep an accurate count of how many 4x4 gauze pads you shoved in there, you typically leave them in there, and that usually doesn't bode well. So the Z-fold gauze is nice because you tug it and it all comes out when necessary. Wound packing is an alternative form of hemorrhage control when direct pressure tourniquets don't work. We try and avoid having you stick your finger in wounds as much as possible, just because of the potential risk of exposure. May be effective for controlling junctional bleeding. You guys know where junctions exist? What junctional bleeding means, and typically in a junction is where great vessels are.
Armpits, hips, elbows,
Yeah,
knees.
absolutely. Absolutely. That's where great vessels are right there. Wounds of the head, back, and extremities may be gauze packed, so your scalp. However, if you have a big wound in the head, there's also potential for a skull fracture. And skull fragments are really, really sharp because remember there's spongy bone in there. And so when it fractures, it can be really sharp. And you can also drive things into a brain. So we use a great deal of caution when wound packing a scalp. We probably should avoid wound packing neck, chest, abdomen, and pelvis. You don't carry enough gauze to fill up a pelvis. So wound packing in those particular areas is not effective. The way to manage hemorrhage is direct pressure as much as you can. If direct pressure isn't working, you need to use more direct pressure. And then if that's still not working, they need a surgeon really quickly. Okay, use direct pressure to stop the bleeding, and basically what that means is you stick your finger in there and you find the vessel and you squeeze it against the bone. We talked about the bone fragments and being careful with that. Use a Z-fold gauze. Combat gauze is preferred but not absolute. Combat gauze means it's impregnated with a clotting agent, a hemostatic agent. And basically you pack it around your finger and you shove it in there. And keep shoving till the wound, till it stops. And then once you shove it all in there, you apply direct pressure, and that almost always works. If it doesn't, you keep shoving more stuff in there. You grab another roll, keep shoving it in there. If you do stop the bleeding or you fill up the hole, you basically pack it all on top and then put dressing around it or hold direct pressure over the top of it then. And that's essentially what wound packing is. Okay, we talked about getting them to surgical intervention if it's not yet. Oh, we're gonna switch.
Yeah.
Okay. Oh, no. I'm good.
Yeah.
That's on the moment. Okay, so essentially with the wound packing procedure, if you have leftover stuff at the end, like when you're shoving gauze into there, you basically roll it up into a ball and then put it over the top and then direct pressure over the top of that. But like I say, this is you should use a high degree of caution if you guys are deciding to use this particular procedure in the field. Because there is a great potential for exposure injuries with it. Precautions about, obviously, I'd go ahead and throw gloves on if you're going to do this particular procedure. Use face and eye protection always. Whenever you have anything that's out that's gooey and oozy and can be splattered, always wear eye protection, always, okay? There's a huge variety of ways for you to get stuff in your eyes, even if it's just oozy. I mean, somebody steps in it, it gets splashed, something gets moved or flung, a C-spine strap dips in it and then gets flung. Put your eye protection on, always. Okay, if the wound continues to bleed or ooze, continue the packing, exerting direct pressure. Always pay attention, if you do this, how many packages of gauze you used to shove in there. Very important. The trauma surgeon needs to know that. Let's see. Because these things are not radiolucent. You can't see them on x-ray most of the time. So make sure that you note for the surgeon how many of these things you shoved in there. Okay, this is the last one I'll go over, and then when you guys get your access to the document itself, if you have questions, contact our office whenever you need to. I'd be more than happy to go over this with you. But okay, so this is a county operating procedure. This is an example of what a COP is. Okay. What do we do? And this is a new protocol that we actually kind of stole it from the Tri-County Protocol group, which is over in Washington, Clackamas, and Oklahoma counties. Crime scenes are something that we respond to on a regular basis, and we wanted to make sure that you guys kind of had an idea if you suspect it's a crime scene. Or if law enforcement is there, obviously it's odds in it being a crime scene are a lot better. There's a few precautions that you need to take when a crime scene is involved or when a crime is involved. Obviously, patient care always is paramount. Okay, but these are these are some things that you guys can pay attention to, take note of when you're managing a scene that's a potential crime. Okay, response and arrival, be conscious of the physical and weather conditions. And this is specific to documentation. Because if it is a potential crime scene, you guys might be called to testify or to give a deposition, and if you have an accurate record of what happened, it's a lot easier to tell an attorney, and especially the cross-examining one, if that's part of the process, what happened in that particular situation, okay? Accurate documentation is really, really important. There's a lot, I know a lot of pre-hospital responders, and I encourage every one of you to do this, regardless of the call you go on, or whether or not you're gonna be the one who documents it. Take notes for yourself, and just kind of keep record of that. You can destroy them and get rid of them after a period of time, but keep records. You don't have to get into detail about, you can identify it by an incident number. You don't have to put names, addresses, things like that, but use the incident number. But take notes for yourself, just in case there comes a time when you need to refer to those for whatever reason. Don't use identifiers. The incident number is the identifier that you would need for that. But, okay. That's my soapbox. I'm off that now. If it is a potential crime scene, limit the number of personnel allowed into the scene. If law enforcement is there, consult with them to see, any direction from them. They might direct you to park, next door, because there's, part of the driveway, the entrance to the home is part of the scene itself. So get direction from law enforcement when it's appropriate. Select a single route to the victim. Okay, that means if you have a full complement of your truck crew, don't forget there's going to be a responding ambulance as well with 2 more people. Hopefully designate a specific response path to the patient and follow that on the way out as well. Note location of furniture, weapons, and other articles. Try to avoid disturbing the scene as much as you possibly can. Total rookie mistake. And this is a personal anecdote. And this is, I was maybe had been a medic for 3 days. This was a suicide by cop guy that was up by Willamette National Cemetery in Portland. The guy took a great deal of fire from law enforcement, and he was ultimately very dead in a particular location. They called us in to confirm death. And I was like, well, he's got parts of him are over here. I mean, you guys they were shot well this time. And they shot a lot, which they have a tendency to do over there. But the first thing I did was walking up to the patient was I started kicking shell casings out of the way because I didn't want to step on them. The cops almost shot me for doing that as part of the investigation. So be cognizant when you guys walk into a crime scene like that, is to try not to disturb anything, because that's, sometimes it can be that, a successful prosecution versus an unsuccessful one. So be cognizant of the crime scene and what's there. If you do see a weapon, make sure you have police deal with it. Okay. And if you do have to move stuff, which is okay in certain situations, move stuff, but make sure you make a notation of where you moved it from or where you moved it to. And in certain situations, especially if you're going to try and resuscitate a patient on scene and that resuscitation fails, leave IVs in, leave ET tubes in, all of that sort of thing. IVs especially are pretty important, because if you have an IV stick and then you pull it out, well, the medical examiner may not know if that was because they have an IV drug abuse history or you guys put an IV in and took it out. Okay, so leave your stuff in when you get there. And then your debris that you have on scene, leave it on scene, okay, because it now becomes part of the crime scene, it becomes part of the investigation. helps document what happened with the patient. So don't remove your stuff, just kind of back away. If you have a cogent victim or one that's making comments or statements, make sure you document them as clearly as you can if they're germane to patient care. You can report this stuff to the investigating officer. If they have clothes on that you need to cut off, number one, try and do it in a way that it can be recreated. Like, don't cut through bullet holes or knife wound holes, or if somebody's clothes are torn, don't cut through those areas if you can avoid it. Or if you do have to cut through them, make sure you make a notation of it, because once again, that's part of the investigation. When they're ready for transport, place them on a clean sheet if you can, and don't interrupt patient care for all this stuff, but if you can, put them on a clean sheet, because anything that falls off them, comes out of them, is part of the investigation, or can be, okay? And then obviously you need your name, agency, and contact information to the investigating officer. That's pretty important. Here in Vancouver, that's not so much of an issue, because fortunately, we only have, for the most part, one and sometimes two hospitals that we go to. Okay, so for police investigations, that makes it a lot easier, because they're not flying around all over the city trying to find where the patient went to. Detailed, we talked about this already, detailed report is really, really important. Note conversations that you had with the family. What were the witnesses doing? What was the rest of the family doing while you're dealing with an arrest situation or trying to treat the patient? Is everyone else sitting around drinking whiskey and smoking cigarettes, watching TV, seemingly not to care about what's happening? Are they involved? Are they, those things are kind of important to note. And then note whether or not you moved anything, the clothing that the victim was wearing, any holes, tears, etc. And then may be helpful for you to complete an incident report after this. If you note a bunch of interesting stuff that isn't germane to patient care, but may be germane to the incident itself. Okay? And then don't offer your opinions. Yeah, it's pretty self-explanatory. A reminder, any location can be or become a crime scene. So always be cognizant of your dispatch information, your surroundings, the nature of the call, especially if it involves kids. Okay, simple little things that you think are wrong with kids might have something to do with child abuse. Always be cognizant of that, especially with kids. And then if you suspect anything, follow your chain of command to make sure that somebody knows about that. Okay? And that's pretty much the whole intent of this. Any question about protocol stuff? Okay.